What's going to be the landscape following this COVID-19 pandemic? Certainly there's renewed interest in extended thromboprophylaxis for the medically ill, something that many of us, I know Alex, you were hoping that we would get people interested in medically ill patient prophylaxis, and now we have this pandemic that's doing that. How are things going to change? What do you foresee for extended duration thromboprophylaxis in medically ill patients, even considering those who don't have COVID-19? Is this going to change things? Maybe start with Alex and then go to Vic.
Sure, Greg. And conceptually, again, I think of this as three phases. As something Vic talked about, the pre-hospital phase. So is there a subset of high-risk patients that have never entered the hospital that we should study? And indeed, we're trying to assess a randomized trial looking at this question, whether there's a subset of the ill outpatient population, those with polyvascular disease, those with key risk factors, et cetera, that would benefit from a purely outpatient-based thromboprophylactic strategy. And I have to say, again, the majority of data in the medically ill prophylactic space in terms of a DOAC is with rivaroxaban. The majority of data, especially data that's relevant to the COVID crisis, such as a D-dimer elevation, right? We've seen that using D-dimer elevations and a thromboprophylactic strategy with low-dose rivaroxaban produces a net clinical benefit in terms of an appropriate risk reduction without an appropriate increased bleed risk. So that's the first phase. The second phase is the in-hospital phase that we just talked about. Is there a strategy of using a more aggressive or even therapeutic doses of anticoagulants confer advantages? And lastly, as you just said, the post-hospital discharge phase. And in that sense, is there an optimal thromboprophylactic strategy? Can we interchange DOACs? Can we use apixaban versus rivaroxaban? I don't know. Again, a lot of the data is with rivaroxaban. It's FDA approved. Apixaban is not. Can we use aspirin? I doubt it. Can we use long-term low molecular heparin like enoxaparin, 40 milligrams? Yes, there's the EXCLAIM trial that Vic and I were part of, but again, there was a lot of bleeding in EXCLAIM as well. And if I had to take a magic wand, my sense is that maybe these patients would benefit from a dual pathway inhibitory approach. So something like low dose anticoagulation plus an antiplatelet based strategy, because more and more data suggests that there's an antiplatelet derived process, especially with oxidative stress, as well as the classic kind of thrombin derived process that is leading to thrombosis. So I would love to study, again, a dual pathway or compass type regimen in these patients with a low dose anticoagulant and low dose aspirin. But those are the three phases that I think should be evaluated. And we're in a tabula rasa, right? This is a brand new territory. We can only extrapolate from what we know, but we know very little in terms of the thrombotic risk in the COVID-19 era.
Vic, what do you think?
Well, I'll be quick. Alex covered that very well, Greg. I just echo what he said. And I was just thinking about COMPASS when Alex mentioned that. Maybe we need a COMPASS type study for VTE. Maybe we need a low dose Xarelto, a low dose DOAC together with an antiplatelet drug in everybody. And maybe in a huge study of 50,000 patients, maybe we'll see that many of us in the population could really benefit from this, even if we don't have any real obvious or visible risk factors for VTE. But something like that should be done. I think if quarantining goes on or comes up again, we may have to look at patients even that don't have COVID, just us regular people getting around, they're pretty healthy, but are sitting around a lot more, telemedicine, things like that, how to study those folks. Again, I think Alex covered things well. Again, I'm gonna finish with an optimistic point and just say, there's so much going on right now. Most of our protocols at Cedars have been cut off for COVID protocols. And so we're doing COVID VT protocols, other COVID protocols, a lot of different drugs. What about BCG? What about natural killer cells? What about a lot of different things we're studying right now. I think we're going to get a handle on this, but I think it's going to come around again, or something like it will come around again. It took us millions of years to evolve as humans to get our genome where it is. It took this freaking virus, what, a couple of months, a few weeks? I don't know.
Yeah.
So it's a scary time, but I think we'll get a lot of antiviral funding, and I think we're going to learn a ton in the future here.
Yep. Yeah, I agree. And I think that it brings us to the end of what's really been a wonderful discussion and a lot of terrific insights into how we approach this pandemic. One of the things that lifts my spirits a little bit as I, try to keep my children from assaulting each other during this no school period of time is the fact that we have so many great minds working on this, and that our research infrastructure is so strong that if there are inroads, handholds that we can find to boost ourselves up and improve care in this setting, we're going to find them. And so I'm encouraged by that, and getting to work with you, Vic, and Alex on these things also makes me feel good. And we all need a little bit of that right now. I want to thank you both for being amazing friends, even better faculty. We got great information. I want to thank everybody who watched this HCP live presentation. I know it's, well, hopefully you are, this will entertain you for a little while at home as you're staying locked down, but we found this to be fantastic. I know I learned a lot, and hopefully we'll do more of these peers and perspectives discussions focused on COVID-19 and how we can care for these patients better. I want to thank again all of you, and that this is us signing off.